Hi, this is Renata Ago, Professional Director at International Wellness Institute. Welcome on the Sport Rehabilitation of Knee Injuries lecture and webinar today. Let me talk about the Sport Rehabilitation Trainer Certification course. The course is running in 15 countries at the moment. It's great for personal trainers, strength and conditioning coaches, physiotherapists, and also for doctors who's working with athletes, injured athletes, and would like to reach the high performance level. Also, it's great for physiotherapists who would like to treat normal people from normal population, who's doing physical activity on regular basis, so working out few days per week on the gym floor. During the Sport Rehabilitation Trainer course, I will show you how you will be able to build up a proper sports rehabilitation program and protocols. We will go through all the muscle injuries, tendon injury, ligament injury, cartilage injury, and even fascia injury. Today, the title of the lecture is Sports Rehabilitation of Knee Injuries. During the course, we're going to hit different structures: ankle, knee, hip, lumbopelvic hip complex, and also shoulder. So today I would like to show you how we will build up the knee injuries, the sports rehabilitation of the knee injuries on the course. It's going to be just a piece of cake. Let me tell you a couple of basic things what we will learn, what you will learn, what I will teach for you during the course. Actually, first we're going to start with the test protocol. We will go through the posture and movement assessment, range of motion assessment, and also motor control test, and switch on firing pattern test, which are extremely important in hip, knee, ankle, and also in shoulder rehabilitation. Then we're going to hit all the correction tools, all the correction manners. We're going to do different kind of stretching. We're going to do different kind of soft tissue mobilization techniques. So we're going to go through cupping, instrument-assisted soft tissue mobilization tools, also flossing, and also the trigger point and dynamic trigger point techniques. Also, joint mobilization going to be a part of the corrective phase. During the third phase, I will show you how you will be able to build up a proper sports rehabilitation training program. Which kind of tempo, which kind of sets, reps, and different kind of exercise you have to use to build your injured athlete back up to high performance. And in the fourth phase, I will show you how you will be able to build up the global stabilization and local stabilization as well. So in case of knee injuries, during the course, we will go through all these four phases. The first one is the test protocols, which contains 10 different kind of tests. Also the corrective part, myofascial release, joint mobilization, and also the activation and the motor control innervation exercises. The third part of the course will contain all the tempos, sets, reps, so actually all the special, the exercise therapy. And the fourth part is all about global stabilization for the core and also for the lumbopelvic hip complex, which is extremely important in sport. Also, in the very beginning of the course, we will go through the muscle chains. Because when you work with injured athlete, it's absolutely different if you compare to normal population. When you work with athletes, you have to know everything about muscle chains and how the muscle chains connect to different kind of sport-specific movement. So today, I would like to show you just a piece of cake from the knee rehabilitation. I know most of you is working as a physiotherapist or a personal trainer. As a physiotherapist or a doctor, when you do a classic physiotherapy, the last point, actually in the classic physiotherapy, when your client can do squat or lunge or even kind of like a scale or a single leg squat, after knee injury. So as a physiotherapist, that's your goal, to hit the full range of movement with no pain, with no compensation. Maybe you will add extra proprioceptive exercise into your physio program. Maybe some cortex training, balance training, different kind of maybe some hops and jumps. But your main goal is actually, by the end of the successful physiotherapy, to make your client, make your athlete to do the squat, split stance, lunges, different kind of closed and then open chain exercise. But for athletes, it's not enough. Because if your athlete can do simple squat or even split squat, it's so far away when your client can do different kind of sport-specific movement. And your client doesn't have to be athlete. Maybe they just do some kind of tennis or squash or different kind of like a hobbies during the weekend. So it's absolutely enough if your client just would like to do some kind of physical activity or just running after the kids. It's absolutely same. They are doing different kind of multi-directional movement. And if you compare the squat or the split stance, which is happening actually in sagittal plane, to the multi-directional movements, which is happening all around the place in transverse plane, there is a gap. And that's what I would like to fill up for you now. Because that's the gap, that's the 2 or 3 months is actually the sports rehabilitation. That's what I would like to teach for you during the course. So I will show you how you will be able to reach the athletic performance or the physical pre-active performance from simple squat and split stance. During the course, we will go through all the functional movement patterns. The most basic functional movement pattern, which is a bilateral movement, is overhead squat. That's pretty common. The next one is split stance. Also pretty common. The next one could be scale or single leg squat, unilateral closed chain exercise during the rehabilitation. The next one could be step up. That's actually the first open chain exercise. After the step up, the next one could be drop jump. That means actually it's not even jump, it's called drop jump because you have to focus on eccentric deceleration and hold it for 3 seconds. That's called actually dynamic plyometric stabilization. When you are holding yourself just on the top of your toes and you drop yourself down and you have to hold it for 3 seconds. During the course, I will show you which kind of progression exists. There are hundreds of progressions. And then we will do actually box tap. So that's going to be the first very explosive movement. And when we finish the box tap, then we're going to do hops, jumps, and different kind of wall drills. How you will be able to prepare your client go back to the high performance. So actually that's how the knee rehabilitation look like. But now I just would like to grab a piece of cake. I choose the split squat. And during this, through the split squat, I would like to show you how you will be able to build proper stable knee with frontal external pulling force. So that's my basic goal, to show you how you will be able to build up proper stable knee in transverse plane. Because that one is absolutely essential if you are working with athletes. Athletes are moving all over the place. They keep twisting, rotating their knee. And if there was a knee injury, and it doesn't really matter, was it a meniscus injury or patellofemoral problem or even an ACL injury, they have to do the same rotational movement later on. So that's what you have to focus on it. during sports rehabilitation. So that's the main difference if you compare proper classic physiotherapy to sports rehabilitation. In sports rehabilitation, we're working on the frontal plane and in transverse plane as well. And today I will show you how you will be able to build it up through split stance. So I just grab one exercise and I will take you through the entire structure. How you will be able to correct it, how you will be able to implement proper proprioceptive exercises into it, and when. That's extremely important. Okay? So first of all, let's talk about the reason of the knee injuries. Especially when we are talking about athletes, the main reason of the knee injuries is the valgus. What the valgus is actually when the knee is rotating internally. So that means kind of like an inward rotation for the knee. What's the reason of the inward rotation? It could be lack of, for example, core stabilization. It could be weak core muscles. It could be lack of lumbopelvic hip complex stabilization. It could be. Also, it could be overusage in the adductors, overusage in vastus lateralis and in TFL as well, and a weakness in gluteus medius and vastus medialis. So there are it could be also ankle. If your client has, for example, pronation in the ankle, or even, for example, the feet flatten on the floor, then it could be a reason of the valgus, which is one of the most common source of further knee injuries, like ACL injury, meniscus injury during sport. So we have lots of different kind of reasons. But our task as a sports rehabilitation trainer is actually find out the reason of the injury and then fix it. Because if we are not fixing it, if we just go through the entire rehabilitation protocol and we don't care about the reason of the injury, in that case, in the near future, it's going to be happened again. So let's start. So from this huge list, I just grabbed the split stance, and during split stance, through split stance, I would like to go through all different kind of stages. We have actually 6 stages what you have to pass during every single exercises. Okay? One more thing which is extremely important. I just mentioned actually how the core and lumbopelvic hip complex is important in knee stabilization, knee rehabilitation, even in knee sports rehabilitation. I would like to talk about 2 main myofascial chain. One of them is called, as a yellow line shows you, is actually the anterior oblique sling system. It contains the adductor complex, mainly adductor magnus. Also, it's going all the way up through the rectus abdominis, external oblique, and go up through the pectoralis major. So again, adductor complex, going all the way up through the rectus abdominis, external internal oblique, and then go up to the pectoralis major. That's called anterior oblique sling. Every single time when you do internal rotation, in that case, you are shortening the anterior oblique sling, and just on the opposite side, you are lengthening the posterior oblique sling. These two are working absolutely in a synergistic way, which means if one of them shortening, then actually just on the back side, the antagonist myofascial chain is getting be lengthened. And it's absolutely the same. If I activate the posterior oblique sling, then I'm gonna stretch and lengthen the anterior oblique sling. And now let me tell you which muscles create the posterior oblique sling. That's a gluteus maximus, and it's going all the way up. It's actually all the muscles is on a one single myofascial chain. So the posterior oblique sling is POS, contains the gluteus maximus, also the thoracolumbar fascia, and latissimus dorsi. So when I shorten the IOS, anterior oblique sling, then just the antagonist muscle chain, the POS, posterior oblique sling, gonna be lengthened, gonna be stretched. But it's absolutely same other way around. If I shorten the POS, the IOS, the anterior oblique sling, gonna be lengthened. It's very important information before we start any knee rehabilitation exercises. So now we know the reasons why, for example, valgus or any kind of knee injuries could be happen. It could be because of previous injury, surgery, repetitive sport-specific movement. It could be because of the valgus. It could be because of lack of neuromuscular control. It could be lack of core stabilization, weak lumbopelvic hip complex. So there are so many reasons. And our task is, when your clients start to do some kind of movement, split squat today, is actually you have to keep correcting. You have to keep assessing. You have to not just ask your client to deliver the exercise, perform the exercise, but you have to keep correcting that knee position. You have to keep correcting that lumbar spine position. And maybe on your next session, on the next day, you have to add extra exercises into your corrective phase. So here we go. Let's start it. We're going to start with a split stance. So I'm going to ask Nikki to do split stance for us. I'm going to ask her to stand just in the middle. Grab your stick, please. Put it behind your back. Okay? Why is the stick important for us? Because as you can see, there are 3 points on the stick: your head, your upper back, and also the sacrum. So you have to keep these 3 points just on the stick. Try to close your scapula, activate your core, and also tilt your hips. So the hip has to be posterior tilted. And now I grab all the equipment what we're gonna need for the perfect correction. So first, I would like to ask Nikki to give me a split stance, please. So what we're going to do now, probably you implemented this exercise into your training program before. But now I would like to show you how you will be able to build it up till actually rotation of your knee. So the first one is Nikki does some kind of, okay, could you just step back a bit? Perfect. Keep your back nice and straight. First of all, you have to assess from lateral view, posterior view, anterior view. What we have to assess? We have to assess not only the foot, but the ankle, knee, hip, and also the lumbar spine, even scapular activation. So there are so many different kind of checking points, what you have to check during the entire exercise. So first, I'm going to ask Nikki to do the split squat for me. She's going down till the thigh is parallel to the floor and coming back up. During the course, I will teach you which tempo you should use. Actually, the basic tempo is 3-1-1. After 5 or 6 hours, you have to call your client, you have to call your athletes and ask them about the injured structure getting be painful, reddish, or maybe the temperature increased, or maybe it's getting be swollen. Then in this case, the tempo was too fast, so you have to change it. What does it mean? From 3-1-1, you have to decrease the tempo to 4-1-1, 5-1-1, 6-1-1. So the first number, actually the 3, means that's the eccentric phase, so when you're lowering the body. The second number, the 1, means the isometric phase, when you just hold on the bottom. And the last number, the 1, means the concentric phase, when you're coming back up. And if the injured structure getting be, as I said, swollen or painful after 5 or 6 hours, first you have to decrease the tempo. What does it mean? Going down for 4, hold for 1 second, coming up for 1. So actually you have to decrease it, but if there is no pain, it's not swelling, nothing, everything is perfect, your client feels pretty good, then in this case, on the next session you will be able to increase the tempo to 2-1-1, and then 1-1-1, and then 1-0-1. So that's what we will learn during the course, how you will be able to change the tempo during the entire rehabilitation session. So now what we're going to do, I'm going to ask Nikki to go down slowly. And what we're going to check today, as I said, we're going to focus on valgus, because that's one of the most common source and reason of different kind of knee injuries. So, as I said, I asked Nikki to please follow this 3-1-1 tempo, lowering for 3, hold it for 1 second just in the bottom, and coming back up. If the knee is getting in, it means there is a kind of inward rotation in the knee. We know already, because I told you, overused muscles could be adductors, vastus lateralis, TFL, and IT band. Weak muscles could be vastus medialis, VMO, and gluteus medius. That's basic information what you have to know about valgus. And what we will do is actually first, we have a proper strategy how we can correct Nikki's knee. First, we're going to work on superficial layers. Secondly, we're going to work on deep layers. Then we're going to do direction correction. And then we will do proper muscle activation. So first, I'm going to ask her to keep the knee straight. So what we saw, her knee went in a bit. I'm going to grab the flossing. Actually, during the course, you will learn a lot about flossing. So it's just one of the way how we can use it for correction. I'm going to put the flossing around her thigh. I'm going to ask to keep your leg straight as much as possible. I'm going to roll it up like that as far as I can. Good. Okay, I'm going to just hide the end of the flossing. Yeah. And what I'm going to do, I'm going to try to mobilize the superficial layers, the superficial fascia layers. Ready, steady, 1, 2, 3, and coming back up. And also you can move with your client. 1, 2, 3, and coming back up. And again, 1, 2, 3, and coming back up. Perfect. And again, 1, 2, 3, and coming back up. And again, 1, 2, 3, and coming back up. So what I did, I tried to mobilize the superficial layers. The fascia already on the skin. I grabbed the fascia and she tried to move, went down, and I moved with her and I tried to mobilize the superficial layers. And I keep checking her knee just in the mirror. If the knee is not moving, is still going inward, that means actually probably we have to hit deeper layers. We have different kind of tools for that one. We can use different blades or knives, or even we can use cup. So what we're going to do now, we do fascia mobilization in movement. So let's see how it goes. So now we hit the deeper layers. I'm going to grab the knife, but I could use the blade and also for the cup. It's absolutely up to you. Okay, keep your leg straight first. Keep it straight. I'm going to put some lubrication on her skin. I'm going to hold the knife. And as soon as she's going down, actually, I'm coming back up and hop back down. And again, she's getting down slowly. 1, 2, 3, and coming back up. And even it could be even slower if it's more comfortable for your client. 2, 3, and coming back up. What I do now, I try to treat the IT band. I'm coming back up to TFL, and now I'm going forward a bit, working on vastus lateralis, minimum 10, 12 times. And then also I can work on the adductor complex, because that one also could be a pretty overused muscle during valgus. The first one was superficial layers treatment. The second one was deeper layers with instrument-assisted soft tissue mobilization and cupping. But if the knee is still rolling in that case, I have to do something. It's going to be the direction correction. Okay? Let's do it. So the same exercise. I'm going to give approximately 10-15% pulling force on her knee. Ready? Keep it straight, keep it straight. Up, 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 up. Yep, keep it straight. Perfect. On her knee, she's going down, and I try to pull her knee out to correct it, to keep it in the right angle. Ready? Steady, go. 3, 2, 1. Hold for 1 second and come back up for 1 second. So 1, 2, 3. Hold for 1 second. The movement is nice and smooth. I just give 10-15% pulling force just to keep the knee in the right angle. Okay? 8 to 10 repetitions. Very important thing, the performance. It has to be 100% perfect. No compensation, especially if we are working with meniscus, no pain. If we are working with muscle injury or ligament injury, tendon injury, we can get into pain 10-15%, but not more than that. And also, there is no compensation, 10-15% pain, and full range of the movement. We are not accept any kind of half a range of movement. It's extremely important. If it's half a range of the movement, then we have to go back to the regression and still working on some corrective exercises. So, her knee went in. First, we did the flossing, superficial layer mobilization. Secondly, we did the instrument-assisted soft tissue mobilization. We hit the deeper layers with the blades, knife, and cup. The third correction was the direction correction. When I try to pull the knee out, obviously, if it's a virus, then I have to pull it other way around. And now, the fourth one is the muscle activation. The muscle activation means I'm going to pull her knee inward a bit, and she has to actually adjust. She has to fire and squeeze and switch on the gluteus medius and the entire lateral chain to stabilize the hip, knee, and ankle as well. So here we go. Let's start at 4 repetitions, please. 3, 2, 1. Hold for 1 second and come back up. She keeps squeezing the knee against the power band. Yeah, she tried to adjust the perfect alignment. That's called muscle activation. That I know you know it. But the most important for us to use these 4 different tools, 4 different levels of correction back to back. And try to push it, yeah? So I try to pull it out. I just give her some load in frontal plane. So that was the way how I try to correct her knee during movement. The first one, superficial layers. If everything go well after the superficial layer mobilization, that's perfect. You can take 1 step higher. But if not, you have to do the deep layer mobilization, then you have to do the direction correction, and then the muscle activation. If one of them is working, then perfect, stop it. You don't have to do the others. But please try to find out which one of these 4 is working for your client. Which one of them is great to adjust the perfect alignment of the knee. Okay, now her knee is pretty good in split stance. So I would like to hit actually the proprioceptive training. Which kind of proprioceptive training we know? Please give me the split stance again. So the first one is cortex training. So I'm going to ask her to do 4 repetitions with closed eyes. So that's the first one. So we have the split stance as an exercise. We have a correction to reach the perfect alignment. We have 4. And now we do the proprioceptive exercises to work on the proprioceptive neuromuscular system as well. So here we go. Please close your eyes and do 8 repetitions as slow as you can. During this exercise, obviously, you have to assess her knee continuously. Yep. If it's not going well, if her knee is getting in, you have to use the same corrective tools. Okay? So if she can't perform this exercise perfectly, you have to work on the superficial layer, you have to work on deep layers, you have to work on direction correction and also muscle activation. The next step is when we use any kind of unstable equipment. I know you're using it. Okay, for repetition, please, Nikki. I'm gonna hold it for you. Yeah, that's great. It's absolutely same. You keep checking her knee. Okay, try to press the external edge of your foot against the bosu. Also try to grab the bosu a bit with your toe, your entire body weight on the calcaneus, external edge of the foot. Yeah, going down and coming back up. Try not to push your knee forward that much and try to keep the 3-1-1 tempo. 3, 2, 1, and come back up. And again. And come back up. And give me one more. 3, 2, 1, and come back up. That was great. And now coming the perturbation. Perturbation means I'm going to ask her to do the same exercise and I give her some kind of pushing movement. And in the middle of the pushing, I will tell her to close her eye. There we go. Perturbation. Yeah. First of all, I'm going to push her trunk, her shoulder complex a bit. And as soon as she's enough stable, I'm going to try to push her femur first. Yeah, from different directions. Calf, tibia, fibula. Yeah. Hold it. Yeah, great. And then even the ankle complex. So that's the perturbation training. And if you would like to, even if you want to work on proprioceptive neuromuscular system even more, you can create kind of like a complex. You can use the unstable equipment with closed eye, or we can use the perturbation with closed eyes. So that's called balance training, actually. So what we did is we have simple exercises. It could be squat, it could be split stance, it could be scale, it could be single leg squat, it could be even step up, it could be drop jump or tap, or different kind of even a wall drill. But the structure is always same. You start with a basic exercise and you have to correct. As soon as you see any kind of deficit, any kind of dysfunction, you have to correct straight away. We have 4 ways. First one, flossing for the superficial layers. The second one, the blades or the knife or even the cup for deeper layers. And if it's not working, you have to go even further. You have to use the direction change, that's the third one. And the fourth one is actually when you're pulling the knee into valgus, and she has to push it out and activating the gluteus medius and the entire lateral chain. And if the knee is in the right position, and actually she can manage this optimal position during the entire functional movement, then we will actually put some extra load to the neuromuscular system. So I asked her to close the eye, proprioceptive training, close the cortex training, or using unstable equipment, what we did. But if you see any kind of inward rotation, you have 4 tools to correct it straight away. So we did the cortex training, we did the unstable equipment, we did the perturbation, and we did the mixture of all of these. It's called balance training, using unstable equipment with closed eyes, using unstable equipment with perturbation. So that was the stage 1. I think it's pretty easy to understand. If you understand this entire structure once, then you will be able to use it on every single stage. Coming to stage 2, it's called anti-rotation exercises. So I'm going to ask Nikki to do the same exercise, but in this case, I will give her some kind of external rotational force. Left leg forward. Yeah, great. So I'm gonna hold the band like that, and that's great. And she's keep doing the split stance. It has to be closed chain. So first we always start with closed chain exercise, as you know. And later on we are going to open chain exercises. So the next one is a pretty important exercise because it's called anti-rotation exercise. Please go down. The tempo has to be 1, 2, 3, hold for 1 second and come back up for 1 second. That's a classic what we did before. If the structure is getting to be swollen in 5 or 6 hours, it's getting to be swollen or it's getting to be painful, then you have to decrease the tempo to 4-1-1, 5-1-1, 6-1-1. So now we do stage 2, anti-rotational exercise. There are 2 different places where I can stand. It could be this way or it could be other way around. So what we're going to do is actually, first I'm going to ask her, I'm going to pull her arm, her entire body this way, and I ask her to lower the body down. 1, 2, 3, hold for 1 second, come back up for 1 second. Try to keep your knee just above the ankle. Perfect, great. Great performance, there we go. And now what we're going to do is actually what you have to understand. On the very beginning of the lecture, I was talking about anterior oblique sling system and posterior oblique sling system. Anterior oblique sling system contains the adductor complex, external internal oblique, and even the pectoralis major. POS, posterior oblique sling system, contains the gluteus maximus, thoracolumbar fascia, and latissimus dorsi. So when Nikki goes down, yeah, she stabilizes herself, her lumbar spine, through the core stabilizer muscles, transversus abdominis, pelvic floor muscles, diaphragm, multifidus, posterior part of the internal oblique. Yeah, she keeps stabilizing the lumbar spine. But when I start to pull, give external rotational pull to her, then in this case, she has to activate the POS, the posterior oblique sling. So when she is getting into the movement, and her knee is going in, that means actually the POS is pretty weak or inhibited. Not the entire chain, it could be just the gluteus maximus, but it is weak as a complex. Now I'm going other way around. So what we're going to do now, I'm going to pull her arm and her trunk again, but in this case, actually, she's going to activate not only the core stabilizers, but also the IOS, the anterior oblique sling. So if the knees start to get in valgus, that means there is an overusage in the anterior oblique sling. So again, if I'm standing here, that means the posterior oblique sling is weak or inhibited, the entire chain or just a part of it. If I'm standing other way around and her left leg is still on the front and she's keep doing the split stance and the knee is getting in, that means even more, as you can see, there we go, that's a great example here. Yeah, perfect. That means the anterior oblique sling is overused, tight. You have to release it and you have to stretch it. For the POS, you have to release it. And you have to do, first of all, isolated strengthening for the gluteus maximus and the latissimus dorsi. Secondly, you have to do some kind of compound complex movement, functional movement to activate it. But it's also going to be the part of the course. So now I just try to touch different topics, and because I would like to give you kind of like an overview how we work in sports rehabilitation. So we finished the stage 1, which was the simple split stance. We did a correction with 4 different ways. And then we did a proprioception, proprioceptive neuromuscular system activation with cortex training. If there is any kind of roll-in turns up, then you correct it straight away. The second one with unstable equipment. The third one, actually, with perturbation, I pushed her a bit, as you saw. And the last one could be balance exercise when you use some kind of unstable equipment, but you are also closing the eye, or you're using, or we use, for example, unstable equipment with perturbation. It's also balance training. So that was the stage 1. Stage 2, we did the anti-rotation exercises. We tried to find out what's the main reason of the valgus. Is it because the anterior oblique sling is overused, or because of the posterior oblique sling is underused, or maybe both? It could be. You have to correct it, and if your client can perform the split squat and anti-rotational split squat perfectly in full range of the movement with no compensation and 10-15% pain, in case of meniscus no pain, then we can take one huge step to the stage 3. In stage 3, it's called tension exercises. The tension exercises, we're gonna do it just against the wall. There we go. We don't need the band. Okay, so I'm gonna ask Nikki to do the same. We do the same movement pattern. Obviously, you will be able to use this structure for step up, for squat, for single leg squat, even for scale as well. So the stage 1 was the simple split stance. Stage 2, anti-rotational exercise. Stage 3, tension exercise. She has to push the stick against the wall as hard as she can. So what she does at the moment, activating the entire core, but also there's an extra firing in the anterior oblique sling because she tried to push the stick against the wall and creating internal rotation in the entire trunk. So please do it for me. Yep. That's great. So now she's firing iOS, POS, core control, everything is fired. If I see any kind of inward rotation in her knee, that means I have to use the flossing, coming the correction. I have to use the flossing to do some kind of superficial myofascial mobilization. If it's not working and the knee is still getting in, then I can use the cups to release the entire iliotibial band, TFL, also vastus lateralis adductor complex. Or I can go even deeper and put some lubrication on the skin, and I just have to hold it, and she's actually moving just under the knife, and I can hit really deep layers during the movement, because that's the most important. You have to keep correcting during the movement. The next one is the direction correction. She's keep doing the tension exercise, activating the core, iOS, POS, but I try to pull her knee out with 10-15% external pulling force in frontal plane. Yeah, that's great. And if it's going well, then I'm coming other way around, because I would like to activate not only the gluteus medius, but the entire lateral chain during tension exercise. That's perfect. Give me 2 more repetition, please. Yeah. And the last one. Perfect. And then I check, because you have to keep examinate, you have to keep assess. So if her knee is in the right position, then I'm gonna grab the proprioceptive exercises. I'm gonna use cortex training. So I will ask her to close her eye and keep repeating the same split stance. The second one, using unstable equipment. So I'm gonna put the unstable equipment just under her foot and keep doing the same. And then we can use perturbation, bit of pushing, pulling movements, and balance exercise, which is a mixture of unstable equipment and cortex training, or unstable equipment and perturbation training. But take one more step higher. If your client is still perfect, then we can ask her to push the stick just against the corner with one hand. Same split stance. What does it mean for us? Is actually, I keep checking her knee. Now her knee is even, now her IOS, anterior oblique sling, is even more activated because she creates that kind of like an internal rotation through the entire trunk. So not only the core, not only the POS, but now we try to enhance, highlight the IOS function. Because if in this case the knee is getting in, that means probably the entire IOS is the problem in the valgus, not only the adductor complex, vastus lateralis, or even the tensor, but the entire anterior oblique sling. So let's see how Nick is performing this exercise. Yeah, she's going pretty well. Perfect. That's great. If it's going well, then what's our task? Give some proprioception into it. Close your eyes. Do the same with closed eye. Put some unstable equipment under her foot. It could be a BOSU, or it could be pretty small, different kind of unstable equipment. Or it could be perturbation with pushing and pulling movement, or balance training. So that was actually the tension stage. Just a bit of recap. The first one is the basic split stance. It could be squat, split stance, it could be scale, it could be any other functional exercises. You always start with a basic movement pattern, basic functional movement pattern. Then you have to correct it. Correct it the superficial layers first, maybe it's enough, and then you will be able to move even further. Maybe it's not enough, and then you have to treat pretty deeper using the instrument-assisted soft tissue mobilization, different tools, the blades, the knife, and cups. If it's okay, you can take one step further. If not, you have to stay here and do the direction correction with the power band. And then you have to go other way around and activate the medius and the entire lateral chain. If you finished, that's perfect. You have to grab the proprioception, cortex training, unstable equipment, perturbation balance exercise. That was the first stage when you do just the basic functional movement pattern. The second one is anti-rotation. We have to do it both ways, and we have to check how the anterior oblique sling system and posterior oblique sling system is overused or underused. And we just checking the knee movements. If it's still moving, then you have to correct it. But not locally. Try it first locally, but probably you have to treat the entire chain. So you have to take your client out of the exercise and actually release the muscle chain, okay? On the third stage, we did the tension exercise, first with both of the hands, activating the core stabilizers and also the anterior oblique sling, but really wanted to see how the anterior oblique sling is activated. Is it overused, underused, or is it normal maybe? Working optimally, firing optimally. Then what we did, I asked Nikki to push the stick down in 45 degrees against the wall, against the corner actually, to creating internal rotation in the trunk. And I went there, checked the knee. If it's necessary, I keep correcting it on 4 different ways, what we learn. And if it's going well, then I grab the proprioceptive training, cortex training, unstable equipment, perturbation, and then the balance training. That was the stage 3. And now we're getting to stage 4, which is extremely useful because that's the first point when we start to do proper rotational movement. And that's what actually we need, especially if we are working with athletes and they are moving multidirectionally and they are rotating and maybe throwing, hitting, pushing, kicking, or running or changing different directions, hopping, jumping. So they are rotating the entire knee inward and outward. And if you not train the knee in transverse plane, then probably your athlete or your client will get injured again, re-injured again and again. So actually, what we're going to do now, we hit the stage 4. That means rotational exercise. So first, I'm gonna ask her to do the rotation and try to focus on, that's the proper split stance. There is a 90-degree dorsiflexion in the ankle, 90-degree flexion in the knee, 90-degree flexion in the hip, and also extension in the hip, 90-degree flexion, 90-degree flexion. That's a proper split stance, what we learn in the university. But in sport, you have to do hip dominant split stance. And that's the point when you have to hit this hip dominant split stance. So it's not about 90 degree, but you are allowed to lean forward a bit. And actually the flexion is not 90 degree at all, but in this position you will be able to create the rotational movement. What you're creating in sport when you are changing directions. Okay? So now we ask Nikki to do the rotation first. We're going to do 4 different rotations. The first one is when she actually just do kind of like a horizontal abduction of the arm. That's the very beginning. So let's start. Yep. And going up. Perfect. And again, go down and coming back up. That's perfect. What we're going to do, we have to check the knee. So first, we're going to check the direction of the knee. If it's getting in, then we know already we have to correct it. With flossing first, the superficial layers, then actually with the blade, we can correct the deeper layers. There we go. Getting into the movement, out to the movement, into the movement, out to the movement, releasing the iliotibial band, TFL, vastus lateralis, and adductor complex. And if it's the knee is still not go straight forward, then we can use the direction correction. And she's keep doing that, so we do the same structure. She used the direction correction, perfect. Yeah, and then I'm going, as soon as she finished approximately 10 repetitions, I'm going other way around. I try to pull the knee medially, great. And she keep pushing her knee against the power band. If it's going well, what's next? You know already, proprioceptive neuromuscular training, which means she's keep doing the rotation, but I ask her to do it with closed eyes, or using unstable equipment, or even perturbation, or balance. So in every single stage, you have to stop, correct it, and hit the neuromuscular system, load the neuromuscular system even more. The next one, when I ask her to do the entire rotation, so it's not about just kind of like a bit of external rotation in the trunk and kind of like a shoulder horizontal abduction. It has to be a proper, nice movement backward. Let me show you my side. So it's going down like that, and it's coming all the way up. There is an external rotation in my hip, and also I point my foot out. So I'm getting in and coming back up. Getting in and coming back up. And that's a pretty interesting point in the entire rehabilitation. Let's see how she does. So I ask her to get in slowly and going back up as much as she can. Perfect, that was pretty good. And now I'm gonna be very naughty because her performance was pretty good, so I give her a plate. It's probably 3 kgs. And going back up, yeah, and that was the point actually. Her knee just moved in. When I put some extra load on the neuromuscular system. Push it out. Yeah, great. This was pretty good. If it's not good, I ask her to keep doing it. Do the myofascial release first. Do the deep layers release secondly. The third one could be the direction correction. And the last one could be the muscle activation. It was pretty good. But now, let me give you a pretty interesting and important information. When she does just the first one, could you just do the first one for me with no hip rotation? Yeah, you can hold it like that, or you can hold it back as you wish. Yeah, lean back. And when she's coming back up like that, and her knee goes in, that means actually the reason of the valgus in this case is muscle dysfunction. In this case, probably adductor complex is overused, vastus lateralis is overused, IT band TFL is overused, and gluteus medius and the VMO is underused. But as soon as she is going up to the entire rotation and her knee is getting in, that means that in this case the entire anterior oblique sling is getting be stretched, and if the reason of the valgus was the shortened anterior oblique sling, then the knee gonna goes in. So when she does the simple trunk rotation, horizontal abduction, and the knee is getting in a bit, that's probably a local muscle dysfunction. As soon as she's coming all the way up and the knee is getting in, that's the problem of the entire anterior oblique sling. What's the difference? If you have only located muscle dysfunction, muscle disbalance, then in that case, you will be able to correct it on the well-known way. Superficial layers, deep layers, direction correction, muscle activation. But if the entire chain is getting be shortened and it's pulling the knee inward that much, that means actually you have to treat the entire chain. So you have to take your client out of the exercise and you have to treat the entire chain. What I will show you during the course how you will be able to treat proper muscle chains and not only isolated muscles. But now, what I want you to understand the main structure. So that was the rotation, and now we take one step even further. So the stage one, simple split sense, do the correction and load the proprioceptive system. Second stage, anti-rotation exercise, do the correction, load the proprioceptive system. Stage 3, tension exercise, we push the stick against the wall. And then downward, do the correction, and then add some extra load to the proprioceptive neuromuscular system. Then stage 4 was the rotation. We did it just with horizontal abduction, and we did it with proper external hip rotation in transverse plane. And we keep assessing the knee movements. During the first one, we just did the local treatment, local correction. During the second one, we have to finish the exercise straight away and treat the chain. And most of the time, that's the main problem when you treat athletes and they have some kind of knee injuries. Their knee is still getting into valgus. You ask them to do hundreds of medius firing activation exercises, like different kind of lateral raises, different kind of side walks and stuff, abductions, but it's not working. The knee is still getting in during the repetitive sport-specific functional movement. Why? Because it's all about the muscle chain. It's not about isolated muscles. But that's a great test to see when the isolated muscle is the problem and when the entire chain is the problem. And you have to examine the iOS and also the synergistically works POS, both of them. But that's actually it's a really great test. And now we get to stage 5. During stage 5, I will give her some kind of resistance. So her rotation was pretty good. And now I would like to add extra resistance into her rotation in the transverse plane. So now, actually, as you saw, First, we did it in sagittal plan. Then we did some stabilization exercises for the trunk. And then we actually created the rotation. And now we give some resistance for the rotation. So we are not actually working with the knee, only in sagittal plan, but all the segments just above is rotating and pulling and pushing the knee. So our goal is actually to focus on the dynamic knee stabilization in frontal plan and transverse plan as well during all these exercises. So now we hit stage 5. I asked her to show us the same exercise. I just would like to put the power band around her. You can use different kind of straps. You can use a power band or whatever you have. The most important is you have to pull the power band all the way around her trunk. And now I ask her to do just the same movement as before. So what I do now, and now she has to push the entire body backward and activating the POS, lengthening the entire anterior oblique sling, as you see, going down and coming back up and focusing on her knee. So now we give some external rotational force to her. Perfect. And now could you just do the entire rotation for me and some external. Perfect. That was really great. And now I keep checking, assessing her knee. If it's getting in, I have to work on her knee. If it's getting in straight away, you know already how can you correct. But if her knee is pretty good, just push it out a bit that way when you do it. Push. Pretty good. Then in this case, what's the next step? We know already we have to load the proprioceptive system. First, I'm going to ask her to close her eye and do the same. The knee went in straight away. There we go. And again. A bit better. It's even more controlled. Perfect. Oops. That's really good. Okay, could you just grab this for a second? And now, what's next? I'm going to ask her to do the same on the unstable equipment. You can keep your eyes open. Going back up. Perfect. Great. And again. Go down. And coming back up. And now could you just step backward a bit with the right one? Backward. That way. Good. Okay. And now she's going down, and I give some perturbation training for her. There we go. I'm going to push her. I can move even the band, or I can push her like that. There you go. So now she actually got kind of like external force, what she will get during the game as well. So our task is to train our athlete to hit the high performance level and load and force as well. So that was the stage 5 when we do the rotation with power band with some resistance, with external rotation in the hip. So the first one was the simple split stance, correction on 4 different ways, and then the proprioceptive training. The second one, anti-rotation exercises. We were just assessing the IOS, POS, and all the overused, underused muscle. The stage 3 is actually the tension exercise, when she pushed the stick against the wall and then downward, and then we isometrically activated the IOS even more and keep watching the angle of the knee, the knee alignment. And then we went to stage 4 with the rotation. The first one was just a horizontal abduction, and then we went up to the entire rotation, externally rotate the hip, because we wanted to see the reason of the valgus in functional movement. But you can do the same even in the sport-specific movement, absolutely same. Just try to isolate the different kind of rotations, and you will see straight away what's the main reason of the inward knee. The next one, we did a rotation with external resistance. We went even higher, and 2 more stages missing. So the first one is, actually, during all these exercises, we just worked in sagittal plan. And if you can imagine the squat with the same structure, it's same. When you do for example, the scale and the splits, the single leg squat with the same structure, it's almost same. It's sagittal plan. But now we would like to hit the transverse plan, as I said. So now we're getting to diagonal lunge. In diagonal lunge, I'm going to ask her to do the diagonal lunge for me. Okay, let's take this off. Perfect. Okay, ready, steady. So that's the first exercise when I actually twisted the knee. Could you just put your foot here? A bit even further. Great, that's it. So the knee should point forward. And as I examining her knee is, if her knee is getting in, then I have to treat the superficial layers, as we discussed before. If it's not working, then in this case, I have to treat the deep layers, or I have to do even direction correction, or even muscle activation. It's absolutely the same, but that's the point when the knee gets pretty hard force, shearing force in frontal plane and transverse plane. But she's keep using her just own body weight. Let's make her job even harder. So first, I'm going to ask her to please close your eyes and just keep doing the same thing. That's great. Okay? One more repetition, please. Perfect. And now I'm going to ask her to please grab the resistance band. Okay? Ready? Slowly. Going down. Perfect. And coming back up. Great. That's a perfect perturbation training. And coming back up. She closed her eye. We did a perturbation training. That's great. Perfect. And now I'm going to ask her to do rotation. So coming down. Perfect. And go back up. Great job. And again, coming down. And I keep watching her knee. And if the knee starts to get in, then I just have to correct. That's all. So that's actually stage 6, when we use different kind of diagonal split stance, even in the back or on the front, doesn't really matter. The most important thing for us to give extra load force, shearing load to the knee in frontal plane and transverse plane. We can do absolutely same, the diagonal split stance, even with a power band to give some extra resistance. We can do it even with dumbbells or with barbells. The most important to understand the basic structure behind. And if the knee is getting to the wrong position, actually, you have to understand what's the reason. In this case, probably it's local. But now, on the level 7, we're going to hit the proper open chain exercise. So what we're going to do is we start from the diagonal split stance, what she managed perfectly, and then we are coming up to lateral, and I pull this up. So she's going down, I'm coming back up. What I'm going to check is the alignment of the knee, because the knee is now is the load and the shearing force on it is actually in transverse plane, and as soon as she's getting in, then in frontal plane. So I keep changing the direction of the shearing force. Transverse plane, sagittal plane, and I add kind of like an extra external rotation into it, like that. So Please grab the weight. Yeah. I'm coming all the way around. Okay, ready? Yeah. Steady. There we go. And we start from diagonal and going all the way up. Try to keep this one straight. Yeah, try to bend the other one a bit more. And externally rotate. Perfect. And again, coming down. And going back up. Perfect. Just pulling pretty hard. Yeah, again, in and out. And external rotation. So try to rotate your hip as much as you can. Perfectly. There we go. Great. Perfect. So try to shorten the iOS, shorten the iOS, lengthen the iOS, shorten the iOS, lengthen the iOS. Okay? And the last one is the stage 7 is when you are working on proper sport-specific movement, which means on this stage, you have to rotate and twist the knee as much as you can. Because if you are not doing it, then your athlete go back to the field as a soccer player, for example, a basketball player or a cricket player, and they will twist it and rotate it. And that's going to be the first time for her. And if the knee is not, it can't, if the muscles around the knee can't stabilize the knee dynamically, then your client won't be able to manage that much force and load in transverse plane during the game. So you have to train the knee to get that load. So in this case, the last one is when you do the rotation, there is in the transverse plane, there's a shearing force in the knee, and going all the way up, and then back down. And you are going all the way up and back down a bit. From here, and back down, and back down. And when you finish it, as I started on the very beginning, that's only one piece of cake. During the course, we will go through the entire test protocols. Posture assessment, movement assessment, range of motion measurements, isolated muscle active motor control tests, different kind of innervation exercises, switch on sequence of firing pattern tests. In the second phase, we will go through all the corrective maneuvers. Which is actually the flossing as a soft tissue mobilization. It could be a flossing, instrument-assisted soft tissue mobilization. We're going to use different kind of tools. Also the cupping technique, extremely important as a decompression training. We're going to do also trigger point technique and joint mobilization. We're going to do passive and active joint mobilization, what you will be able to do manually, or what you will be able to teach for your client to do it alone, even with a power band. In the third phase, we're going to do the exercise therapy. I will show you how you will be able to use the 2-platform or 3-platform models, all the parameters, tempos, reps, sets, everything. And during the fourth phase, we're going to do global stabilization because, as you saw, extremely important to build it up. So, test protocols, correction, exercise therapy, and in exercise therapy, we will go through all these exercises from the very beginning. Today, I just picked the split stance for you, but there are hundreds of exercises where I show you and show you how you will be able to treat it, or how you can release different kind of overusage, or how you can activate different kind of underused muscle in motion. Because isolatedly, it's pretty easy. Or do the myofascial release on passive way. But in movement, it's totally different because we have to think in muscle chains and movement and repetitive sport-specific movement. So it's absolutely different. So I hope you liked this lecture today. It was lovely to see you. And if you are interested in any of the sport rehabilitation courses, then more than welcome. So see you in your country. Your course is coming. Sports Rehabilitation Trainer course in few months. So see you there. Thank you so much for your attention.